It is really my honor and privilege to introduce our next speaker. Dr. Wilder is a former mentor of mine and was really my inspiration for working with injured runners. Dr. Wilder is the Harrison Distinguished Associate Professor and Chair of the Department of Physical Medicine and Rehabilitation at the University of Virginia. Dr. Wilder received his medical degree from the University of Virginia in 1988. He completed his residency at the Baylor College of Medicine in Houston and primary care sports medicine fellowship at the Nurse's Orthopedic Sports Medicine Clinic. From 1993 to 1998, he practiced at the Baylor University Medical Center in Dallas, where he was the Director of Sports Rehabilitation, Medical Director of the Runners Clinic at the Tom Landry Sports Medicine and Research Center, and the team physician for numerous clubs and schools, including serving as the head team physician for the former Dallas Burn, now FC Dallas, of the Major League Soccer. Since 1998, Dr. Wilder has practiced at the University of Virginia, where he directs the Runners Clinic at UVA and the Speed Clinic, and serves as a consultant physician at the Charlottesville Track Club and team physician for Ragged Mountain Racing, a post-collegiate Olympic development team. He is event medical director for numerous races, including the Charlottesville Marathon and Charlottesville 10 Miler. He and his wife Susan live in Charlottesville with their 4 children, Lauren, 17, Stephen, 15, Ryan, 13, and Carolyn, 11. He attends a lot of soccer and lacrosse games.
I want to thank Greg for inviting me to be a part of this. This will be completing a year-long tour where I've attended 7 different running medicine symposiums around the country, and certainly coming to Eugene is an extremely exciting destination event for me. Following Jim's talk, I want to tell you too, you've cited work by all the different speakers that have come to these meetings, and I want to tell you, you just delivered the most balanced talk that I've heard of Barefoot Running to date, so you're doing good work here, and I won't comment any more on that other than say good job. So I'm talking about evaluation of the injured runner today. Before I get started, I just want to show hands. How many physical therapists in the audience? Physicians? Athletic trainers? Mixed group. What I'm going to present, depending on your level of training, especially if you're a manual therapy trained physical therapist, may not necessarily be new, but what I hope to do is to deliver a framework as to how to package and approach our evaluation of the injured runner. As those of us who treat runners know, rarely do we get that very simple traumatic injury, easy approach to fixing this thing. In my office now, over the years, my practice has kind of morphed to where I would say probably 90% of my patient population are runners. The majority of those folks are coming in having seen multiple clinicians, so that by the time they're seeing me, they've been through a lot of traditional treatment and evaluation. And my job is to figure out, okay, what are we missing here and what can we do different? And that's what I hope to kind of package today, is a kind of a standardized approach to the evaluation of the injured runner that hopefully will help us in uncovering some of these clues that can help us, offer a little bit more to our runners and get them back on the road and the track. So our objectives today, by the time we're done with it, you should be able to list common intrinsic and extrinsic risk factors associated with running injuries, perform a running-specific history detailed to identify potential training errors, perform a biomechanical screening exam to identify potential intrinsic risk factors for running injuries. And that's really what I'm going to spend most of the time talking about, the biomechanical and functional screening that we do in the office. Just some quick epidemiology: 30 million active runners, 70% of all runners will sustain an injury significant enough for them to lose at least a week of training during the year. 40% of running injuries occur at the knee, 15% shin, ankle, hip and groin, or shin, Achilles, hip and groin, 10% foot and ankle, 5% spine, 20% 25% of recreational runners each year will report a significant injury compared to 5% of elite. You may look at that and say, well, that doesn't quite make sense because our elite folks are doing so much more training, as we'll talk about and kind of hammer home as we go through this. It's not necessarily the absolute amount of volume or intensity that predisposes us to injury, but rather transitions in our training. And it's important for us as clinicians to find that transition. That's what we need to identify, so that when we correct the injury, we're not sending them back to the same environment from whence they came. Now, most running injuries, as we know, are overuse, but not all of them. We get traumatic injuries. 4% hit by dogs, 0.3% hit by bicycles, 0.6% hit by cars, and 7% report being hit by thrown objects. So the study you want to do next is find out how many of those 7% were able to put that thrown object back in the back windshield of that car. If you take anything from what I talked about today, just this slide here, two principles. Principle of transition, principle of culprits and victims. Principle of transition states that running injuries occur when there has been a transition in our training, in our life, in something. And that's really what we're going to look at with the history. We want to sift that out. What has changed? Why are you in my office now? What happened around that time of injury or soon before that that caused you to break down? And then the principle of culprits and victims states, it kind of underscores the biomechanical contributor to our injuries. So the victim is the injury. It's the plantar fasciitis. It's the Patellofemoral Syndrome. It's the Achilles tendonitis. The culprit, though, are the biomechanical factors that have led to that injury, and those we need to seek out and address as well. Intrinsic abnormalities and extrinsic abnormalities. Intrinsic, they're inherent to the runner. They're physiologic. They're anatomic. Malalignments, muscle imbalances, inflexibilities, muscle weaknesses, instabilities. Those we seek out with our exam. Extrinsic abnormalities are basically training errors. Too much, too soon, too fast, equipment, environment, techniques, sports-imposed deficiencies. These are things that we need to identify so that we can correct them when we get them back to the sport. So our examination, we do not just the site-specific exam that we're going to do on everybody. We do a detailed running-specific history, a biomechanical assessment. What I'm going to run through, really, once you get it clicking, it's 5 extra minutes to your exam. The site-specific exam, we always do a dynamic exam. I always look at my runners walking and running, because things change and they don't always change the way that you might suspect them to. And Jim pointed out nicely, one aspect I've seen at least a few runners, especially when you take your shoes off and watch them run, they're running with different patterns right to left. So I mean, geez, what is the proper shoe or proper pattern for that person? They're not even giving me the same pattern on one side to the other. And then ancillary testing is necessary. The history. What are some important things that you need to ask about in that running-specific history? We're going to be asking about the details of the injury. We're going to ask about their past medical history and their family history and their social history, all the stuff that we need to do to complete our standard history forms. But running specifically, I want to know about the prior running injury history. What's the number one cause or the number one risk factor of having a stress fracture in runners? Having a previous stress fracture. That prior injury history becomes very important in identifying potential risk factors or patterns of injury that may lead us to some of the factors we need to correct. What team are they running for? What club? This gives me a lot of information about what type of training, what pattern of training they're doing, the volume, the intensity. Identify transitions. Have they increased their mileage, their intensity, changed their surface, changed their shoes? Very subtle things can lead to that specific injury. I'm always intrigued with folks that have been uninjured for years and years and years, and then when I ask them, well, okay, what shoes are you running? They tell me, how long have you been running those? Well, this is my second pair. Well, what were you running before that? And you find out that 15 years prior to that, they're running a particular model. And, all right, 15 years, non-injured. Why did you switch? I don't know. It looked good. Or somebody recommended it to them. Something that may serve as a significant factor. How many miles per week? The literature tells us that we start to see a rise in injuries when runners start running 20 miles a week. It goes up more sharply at 40 miles a week. So from the literature, I'm more interested in, has that changed? Has there been a significant increase in their training? And that increase may be going from 10 to 20, or it may be going from 110 to 120. 10 to 20 doesn't sound like a whole lot, but that's 50 or 100% increase in their mileage. That's a lot of mileage increase. What's their injuries go up when that long run each week is more than a third of the weekly mileage. Well, in Charlottesville, Virginia, we have a lot of novice marathon runners. We're getting into the craze. We have these different training programs, and a lot of the folks they'll train for the women's or the men's 4-miler program. It's the first time they've been training, and they just get bit by the running bug. So they train for the Charlottesville 10-miler the next year, and now they're really bit with the bug. So now comes the marathon training. And these 3-4-day-a-week marathon training programs where we do short, long, you're necessarily going to be that. And then, that's one of the challenges of the sport, but we recognize that's going to be a risk. So if they're long run more than a third of their weekly mileage, it's a risk factor. What's their intensity, and has that changed? What surface are they running on? Now, people often ask me in the office, is it better for me to run on grass, trails, bark, whatever? And I have to tell them, good question. We don't know. I mean, we used to preach, soft surface must be better, but we don't know. Jim mentioned in his talk the principle of muscle stiffness and leg stiffness. Ben O'Neill has talked a lot about muscle tuning and vibrations, and we just don't know. But what I do know is that I see a lot of injuries in folks who have changed that surface. They're a treadmill runner because it's convenient for them, but then they're racing on asphalt and they come and beat up and they're wondering why. Well, what's going on with their muscles and how that's being affected and the transmission of forces, we've had a change here. Or they've been training on asphalt for years and ages, but they get bit by the trail running bug. That transition may need to happen a little bit more slowly. Shoes and orthotics, and do we think that they're proper for their particular foot type and running patterns? We want to look at it dynamically. Are they cross-training? How much are they doing? I share the story. In fact, Greg might have, and I know Greg has seen this particular patient, but I can't mention the name, but you might remember the story. First time I saw her in the office, she presented with a variety of different injuries. Her running history, she was running a fair amount. She was in her mid to late 40s. She was running around 40 miles a week. Running history seemed pretty sane. But when I asked her about cross-training, how much cross-training did you do? So she says, I love the elliptical. And I said, well, how much of that are you doing? And she says, 3 hours. I said, okay. How do you divide that up? She says, well, what do you mean? I said, well, is that an hour 3 times a week? Or she goes, oh no, a day. So in addition to her 40 miles a week, she was doing 3 hours a day on the elliptical. She was burning a lot of calories doing that, which created another issue that we had to address. What are the goals? You gotta know what the goals are, short-term, long-term, so you can pattern your training and their running volume and intensity into that. Big one I like to sit down. What are your life stressors? Are you fatigued? Are you running every day, breaking down? I just had one of our Ragged Mountain racing runners, world-class triathlete in the office recently, and as we broke things down, looked at her training log. She started writing notes about how tired she was, how fatigued she was. And we looked at her, what was going on outside of the training, and she was working, studying, and there's a lot of things going on. She was running fatigued all the time. So one of the big factors with her was trying to find that balance, so we could minimize that. And all females, we want to ask about eating disorders, menstrual irregularities, any personal or family history of bone density issues. Ask. If you don't ask, you're not going to know, and if you don't know, you're not going to treat it. And it's very prevalent, very important. One does not have to have overt anorexia or bulimia to qualify for an eating disorder. Restricted eating is important. The general approach to women with multiple stress fractures in the past is just to go right to the hormonal replacement. What we found is, perhaps more important, is just making sure women are getting enough calories, and oftentimes their menses regular, just because they're now starting to get normal calories. It's so important to ask, and we'll ask that in all of our high school and college and post-collegiate female athletes, even if they're not complaining of stress fractures. Physical examination, biomechanic exam, site-specific exam, walking and running, ancillary testing, looking at their shoes. So let's go through this. We're going to go through this pretty quickly. A lot of this will be review, but again, look at it as a framework of things. We look at both standing, sitting, supine, sideline, prone. Standing, get the guys with the shirts off, shorts, girls, sports bra, or at least a tank top. We like non-carpeted floor, because even the carpet can change your mechanics. We're going to look front, side, and back when they're standing. What are some of the things we look at? Whoa, that's a big list. But you can, like I said, screen through this in pretty quick fashion. Want to look at their general alignment. Want to look head to toe. Look at their shoulder. Look at their hip alignment. What's their leg length? How deep their iliac crest? See if they're even. Start asking yourself the question. Do I think it's a true leg length or a functional leg length discrepancy? What's their patella position? Is it looking straight at you? Is it looking up? Is it squinting, might be predisposed to patellofemoral syndrome? What's their gross foot type? High arch, neutral, flat. We look at sacroiliac alignment and function. We look at their spinal alignment. Important clues here. We just saw that. Here we are starting to glean now. Boy, there's a lot of motion going on. So I was pretty impressed looking at that amount of motion that was going on with those markers when folks are running. Look at their segmental motion. So bend forward, touch their toes, lean back, see if you're seeing normal motion, reversal of that lumbar lordosis as they're bending. Look at the trained Dellenberg. Look at their tibial stance. Do they have normal tibial varus? Look at their rear foot alignment. Is it neutral? Is it varus? Is it valgus? We look at subtalar motion and tibialis posterior just function by having them stand on their toes. Do they have normal inversion of their heel when they stand on their toes? Look at the amount of dorsiflexion. To run normally, you've got to have at least 30 degrees of dorsiflexion. So I have them turn to the side, keep their heels flat, bend your knees, go down as far as you can go. And if I'm not seeing 30 degrees, we're not bending at the ankles. We're going to be bending somewhere else. That center mass wants to be where it wants to be. So we're going to either get it at the ankles or we're going to get the knees or the hips. So if we have inadequate dorsiflexion, it may affect our motion and loading patterns. Flexibility, hamstrings and gastrocs, you can do when they're standing. So bend forward, touch your toes. You can see what their soft tissue flexibility is with the bending at the ankle test. Just look a little bit at the SI fixation and flexion test. We always want to look at their sacroiliac motions of palpating the posterior superior spines and then having them lift their knee to chest. And normally we should see that thumb swing down. If it stays the same or moves up, there may be a dysfunctional pattern. And the same with the flexion test. Palpating the posterior spines, that thumb should swing down. Or if it stays the same or goes up, might be a dysfunctional pattern. Trained Dellenberg, we'll talk about some functional tests towards the end, but it's just standing on one leg. Are they able to keep their pelvis stable? If their pelvis drops, that stance side probably has some either weak or just inadequate firing of their pelvic stabilizers, and that can have a dramatic effect on their mechanics during running. Sitting allows us to have a further pelvic assessment. If you saw pelvic obliquity when they're standing, check it again when they're sitting. If things have evened out, you might have a true leg length discrepancy. If we're seeing that they're still, still imbalanced, we may be looking at a sacroiliac or sacral dysfunction. We start our patellofemoral joint examination. We can look at the position, we look at the tracking, we feel for crepitus. You can look at flexibility and strength to a degree, so hip flexors, knee flexion, knee extension, dorsiflexion, plantar flexion, do your sensation exam, reflexes when necessary. We lay them down. Actually, I'm going to go back and just talk a little bit about the patellar tracking here. Normally, when they're extending and flexing, we should see at most a 2-to-1 ratio of lateral to superior motion. If they're moving more lateral than 2-to-1, they're probably having excessive lateral motion and they're predisposed to patellofemoral syndrome. Supine, we can measure the leg lengths, anterior superior iliac spine, the medial malleolus. We can look at lower extremity alignment. We look at femoral torsion, tibial torsion, the Q angle. We do a further patellar examination with patellar tilt and glide. Look at flexibility, the hip flexors, hip internal external rotation, the hamstring. So let's illustrate some of these. Measuring anterior superior iliac spine, the medial malleolus. I don't always measure this with a tape measure, but I at least eyeball it all the time. So easy to check. And if it's something you miss, and you're missing something that may be contributing to their injury, and it's easy enough to try to correct. Femoral torsion, normally we have a little bit of femoral anteversion, so you're palpating that greater trochanter, and you're just kind of moving that kind of in and out to feel it most lateral, and then you're looking at how the femoral condyles align to the plane of the table. Tibial torsion, normally we have about 20 degrees of external tibial torsion. If we have abnormal, that can affect our mechanics. Q angle, measurement of the patellar alignment. I don't always measure this with a goniometer, but I'm at least eyeballing, and I'm also looking for symmetry. For those of you know, we're looking at the angle formed between the anterior superior iliac spine, line drawn through the center of the patella, bisecting with one going from the center of the patella to the tibial tubercle. And generally 5 to 10 degrees in men and 10 to 15 degrees in female, considered normal, and if it's more than that, may be predisposed to patellofemoral syndrome. Patellar glide. Folks with Patellofemoral Syndrome, get your hands on it. My sports medicine mentor, Bob Nurse, an orthopedist in Arlington, Virginia, he used to claim when he would examine patients with knee exams that this was his MRI. Of course, this is back in 1992 when MRIs were just getting to be used, but great amount of information you get by getting our fingers on the patient. So palpate around the patella, palpate underneath it, palpate the femoral condyle, see if you can isolate where that pain is coming from. It can start to give you an idea of what's going on with these folks. Look at their patellar tilt and glide. Move that patella side to side. See how much motion you get. You'll be surprised at the variance you see. Some people don't move at all. Some people you feel like they move so much you can probably dislocate them right there in your office, but don't do that because that feels bad. So normally if you pull the patella fully laterally, you should be able to get at least 5 to 10 degrees of tilt. If not, they're a little tight. If you divide the patella into quadrants, you should normally be able to move people perhaps 2 quadrants medially, up to 3 quadrants laterally. You're moving folks more than 3 quadrants laterally. Those folks that are about ready to pop out, they probably have some patellar instability. On the contrary, if you're not able to move them at least a couple of quadrants medially, they probably have tight restraints. Thomas test for hip flexor flexibility. So I started having my low back pain in October, but as a typical physician, I don't get around to seeing our physical therapist until about 3 weeks ago. I just don't have time. And one thing that became evident on the examination, that this right side where I've been living with extension pattern pain now for over 6 months, I had a 45-degree hip flexor contraction 3 weeks ago. We've been working on it. Came out in the Thomas test. Had I ever even tried to do it on myself? No, because I don't stretch my knee hip flexors. I don't have time, but now I do. So check this. Why is this important? If we're having real tightness in our hip flexors, we're drastically affecting our spine mechanics. So they may not be complaining of their hip as their primary site of pain, but it can affect our mechanics proximally and distally. Look at hip internal external rotation. Do the popliteal angle. Measure their hamstring flexibility. Runners, you should be able to get them into 90 degrees of hip flexion, 180 degrees of knee extension. If not, they're tight. Sideline test, over test. Looking for IT band inflexibility. Abductor strength in the open chain position. How many folks test this in all the runners? Okay, some. Good. Abductor strength of the hip is so important. We're talking about our stabilizers. If these muscles aren't working strong, what's going to happen? I hit the ground. These aren't firing. I'm going to drop. That's my dynamic Trendelenburg, right? What happens if I'm dropping? My femur internally rotates and cross adducts. My tibia internally rotates. I pronate more. All the way down the chain, I'm getting more motion because up here, I don't have good stability. We do find folks that have good strength and yet bad dynamic control. Mike Fredrickson, who's the team physician at Stanford, he talks of the 2-finger test. So he says if he can push somebody down in abduction with 2 fingers, they're prone to problems with patella, shins, foot, and ankle. 2 fingers. Now the folks he's screening, they're Foot Locker All-Americans. Foot Locker finalists. That's who goes to Stanford. And yet you're able to overcome them with 2 fingers. Interestingly, at our running medicine conference a few months ago, I did exams on 2 folks to illustrate, one of whom was my daughter, and that's all I'm going to do, just point her out. I won't embarrass her anymore. I could probably have done push-ups on her abductors all day long and never budged her. Then the next was one of our presidents, who's an all-conference runner from William and Mary, very accomplished distance runner, 2 fingers, down. So, 25-year-old male, elite distance runner, very poor strength. 17-year-old, tremendous strength. So, you'd be surprised at the variance that you see. Prone evaluation. Quad flexibility, looking at dorsiflexion, the open chain position. Hamstring strength, you want to look at knee flexion, hip extension. Look at their subtalar motion, mid-tarsal mobility, subtalar neutral examination of the sole. Let's run through this. Subtalar motion, inversion, eversion. I like to see 3 to 1. 30 degrees of inversion, 10 degrees of eversion. And you'll see variability. Some folks are very mobile, some folks that aren't mobile at all. Mid-tarsal mobility, I want to grasp that calcaneus, hold it steady, and then I want to look at their mid-foot motion as I move them into inversion and eversion. I'm looking at the quality of motion. I'm also looking at symmetry. You'll see some folks that they are rigid, stiff, immobile on one side, very mobile on the other side. And these are things that can create imbalances. Subtalar neutral examination. This allows us to identify our alignment in folks. And the subtalar neutral position is just it's a defined position so that we all know what position they're in when they're being measured. You just basically feel the talus equally with your thumb and index finger, and if you feel that bulge the same, that's your subtalar neutral position. We can look at the relationship between the leg and rear foot, the rear foot and forefoot, and then the first ray. So they're in subtalar neutral position, and we can look at the leg rear foot alignment, and we can classify that as neutral. Varus or valgus. Same thing with the rear foot to forefoot. So we're looking at the planes of the metatarsal heads. If they're nice and flat, that's neutral, but if that first ray is higher, they're probably in a varus position. If it's lower, they're in a valgus position. First ray mobility. I should be able to grasp my metatarsal heads and move that first ray up and down just about where the bottom of the first ray goes to the top of the second metatarsal, and conversely, the top of the first ray comes down to the bottom of the second metatarsal. And if they don't have that much mobility, they may have some stiffness within that first ray. Look at the sole. Just like we look at the shoes, the sole pattern can also tell us where they're weight bearing. Site-specific examination. After we've gone through all this, now we focus on the area that's particularly injured. Functional screening. How many folks doing a functional screening on their folks? Yeah, good. The screening that I use in the office, I look at single leg stance, single-legged squat, bilateral squat. I want them to be able to demonstrate that they can isolate their flexor hallucis brevis. I like the step-down test, the star excursion test, the swing test. Single-leg stance, I just have people stand on one leg, eyes open, eyes closed. And try this at home. You'll be surprised at how many of you get unstable. Just stand on one leg, and I want their pelvis to stay stable. And I also look at their foot and ankle. I don't want to see them gripping, just fighting to stay stable. If these muscles here are good and stable, and I have good stability down at my foot and ankle, it should be pretty easy to just stand and not have any problems with dropping my pelvis. We do that eyes open, eyes closed, 30 seconds each. Single-legged squat. So now I'm going to have them bend their knee, and I want them to be able to bend their knee and move that knee to the very tip of their second toe. Bilateral squat. Now they're keeping both feet steady, and again, I'm looking at where those kneecaps are going. Step-down test, they're standing on a box and doing a single-legged squat. We're going further to touch the floor and come back. Through these tests, what am I looking for? I'm looking for to see if they can keep their pelvis stable. I don't want them dropping their pelvis on the non-weight-bearing side. I don't want them cross-adducting or internally rotating their femur. And I don't want them gripping for all daylight with their toes to keep their stability. The star excursion test, kind of moving in different directions. There's actually been different patterns identified with certain injuries, including chronic ankle instability. The swing test is another one I like. Standing on a box and just moving that leg through the running motion. And can they maintain a stable pelvis? Can they do this with normal spine mechanics? The flexor hallucis brevis isolation test, I really like that. Standing on one foot. And what I tell folks is I want you to be able to keep your big toe on the ground and lift your other four up. And you'll find folks, they just can't do it. I'm doing it right now on my shoe, and it's because I practice it a lot and it's pretty easy. But that flexor hallucis brevis is a very important stabilizing muscle of that medial arch going into our forefoot. If we can't isolate that, we're probably having to call on other muscles. Shoe exam. Do we think it's the right type for them? How old is it? I generally preach to folks 350 to 400 miles is the lifetime of the shoe. Are they old? Are they worn? And a lot of neat new stuff coming out with shoes, especially with the barefoot stuff. But as Jim mentioned, we're still at that point now where we're peeling this onion here. And we're not ready to tell people that this is the answer to all injuries. I'm on a couple of fairly famous folks who are delivering these running blogs who have just completely gone to preaching that this is where we need to go. I look at it as, boy, we've got a neat new element here that we really need to study to find out who this can benefit and how. Do we think this is a proper shoe for their foot type and their running pattern? And remember that transition. Watch them walking and running. I have a treadmill in my office, and I watch them walking in bare feet, running in their shoes. If they have transitioned to barefoot running, I'll watch them running barefoot or in their minimalistic shoes as well. A lot of different patterns that we see that we may not not expect just based on their static dynamics. Ancillary testing when appropriate. So to summarize, as you're doing your evaluation of the injured runner, it's got to be a little bit more expansive than what we might do with a simple traumatic injury. In addition to that site-specific exam, make sure you're doing that running-specific history to identify transitions. Do your biomechanical screening and your functional screening to sort out some of the immobilities and flexibilities and abnormal motion patterns and dysfunctions that may put abnormal stress on the runner when they're training. And when you're doing that, the likelihood that you're going to give them a rehabilitation package that's going to get them back to running and staying there is going to be much better. So thank you.